So, what is being done against substitution, against drug dependence in prison? Outside in freedom, when we look at how we responded to HIV, but also hepatitis C and B, we see that needle and syringe programs, the ideally 24/7 accessibility and availability of clean syringes and needles are a main factor which led to the success to combat HIV, but also opioid substitution treatment is a major fact that people do not continue to inject drugs just because they are stabilized and they are in a medically supervised treatment of opiate substitution treatment. And you can see it on the numbers throughout Europe. Some 600,000 opioid users are in substitution treatment in many European countries. And when we look at the comprehensive package, which has been issued by the UNODC, WHO, UNODC, UNAIDS, and ILO, and many other international organizations, they have set up 15 interventions, all with a bulk of scientific evidence, 15 interventions which make up the so-called comprehensive package. And we see here that all of these 15 interventions are of major importance for responding to HIV and hepatitis C, like information, education, and communication. We need to have messages adapted to the skills and to the life environment of the target populations. We do need to have HIV testing and counseling, treatment, care, and support. We need to have condom programs. I will not go through all of these messages because I'm pretty sure that you know all of them. But I will highlight some of these 15, which I will go a little bit deeper into. One is condom programs in prison, and the other one is drug dependence treatment, mainly opioid substitution treatment, which has been shown as the major intervention, the major response to stabilize people and to keep people healthy. And the last one is needle and syringe programs. But also other interventions play a key role in the way of how we respond and combat in HIV and hepatitis C. For OST, as the abbreviation for opiate substitution treatment, we do have a systematic review carried out some years ago, and we discovered 21 studies in our review, including 6 randomized controlled trial studies that show that OST is effective among the prison population. There's strong evidence that it reduces heroin use, injecting and syringe sharing in prison if doses are adequate. It increases in-treatment entry and retention after release. It is responsible for, very important, for post-release reductions in heroin use. There is evidence for pre-release OST reduces post-release death. I will come to that afterwards. And there is some evidence regarding crime and re-incarceration, which is equivocal. And we do not know that much about the lack of studies addressing effects on incidence, HIV, and hepatitis C rate. But studies clearly show that a disruption of continuity of treatment, especially due to brief periods of imprisonment, is associated with very significant increases in hepatitis C incidence. So people get out without any treatment in prison, left out untreated. It is almost 100% sure that they will fall back into their habit they had before the imprisonment. And the relapse is quite normal, and the relapse is associated with dirty needles and syringes with a high risk of overdose. Therefore, we did a guide which has been translated in several languages, in Russian, Czech, Azeri, German, and many other languages, on how to carry out opiate substitution treatment in custodial settings. My colleagues Andrej Kastelic and Jörg Pond were the main authors. And it's a practical guide in which we are showing how to set up an OST program in prison, how to conduct it, whom to involve, and what to keep in mind. So it's still very up to date. OST is not shown in many countries, in many prisons in Europe. You see here the green countries. That means that opiate substitution treatment is available in all prisons. The yellow shows that OST officially is available in all prisons, but low coverage due to additional requirement for abstinence. The blue, the countries in blue, means that OST is available, but continuation is possible only if treatment was started prior to incarceration. The orange countries mean that OST is available in some prisons, but not in all. You see Germany in the middle of that chart. And in some prisons, OST is not available in prisons at all. For instance, in Slovakia, and gray, it's not part. We do not know anything about that. So you see here, opiate substitution treatment is available in all but 2 countries in Europe. Lithuania just recently introduced OST, so this is no longer true. Slovakia is the only country in which OST is not available in prisons. In 16 countries, more than 75% of prisons per country provide OST for prisoners. In 3 countries, the coverage rate is 25 to 50% of prisons, while in 7 countries, less than 25% of prisons provide such service. And again, my country, Germany, is in blue, so the coverage rate is below 50%. That is an alarming signal, because in that way, prisoners do not benefit. They do not benefit at all from the progress of medical addiction treatment, and OST is such a treatment. We now have several medications on board. In Germany, in Freedom, 7 medications are authorized, 2 forms of methadone, then diacetylmorphine, then retarded morphine, codeine, buprenorphine in various forms of application. So there's a lot of progress outside, but this has not entered the prison gate yet. The number of inmates in OST in prison, we see here on the chart above. The top treaters, so to say, in Europe are England, respectively UK and France. In England, more than 20,000 of prisoners are included in an opiate substitution treatment. In France, approximately 15,000. In Germany, these are some old figures that has been boosted up considerably, up to 4,500, and even Spain has made some, also Spain has made some considerable progress. And on the statistics below, you see the prevalence of heroin use before imprisonment among prisoners and percentage of prisoners being on OST in 2016-17. You see here the data are a little bit outdated. Some recent things have been achieved. And you see here, for instance, Slovenia, the prevalence of heroin use before imprisonment is at 44%, and inside prison, 20% are receiving OST. We see another example, for instance, Ireland, also a high number inside prison and not that many outside. And Denmark, the other side, a low percentage of prisoners being in OST and a high number, double the number of people in heroin use before incarceration. So where have we got from here with opiate substitution treatment in the last 30 years in European prisons? Not very far, I would say. There is movement, but it could have been done we could speed it up considerably, and the coverage still is low. The detoxification models are very heterogeneous. The maintenance treatment schemes vary considerably from country to country. OST as relapse prevention is only possible and is only being offered in a few countries. And the OST provision in general in prisons varies from country to country, from region to region, from prison to prison, and even from doctor to doctor. There's a very famous case with which we are arguing since 2016. It's a case before the European Court of Human Rights in the case of Mr. Wenner versus Germany. Mr. Wenner was a prisoner with a long-term and manifest dependence to opioids. He has been in programs long before imprisonment. When he entered the prison gate, the continuation of his opiate substitution treatment has been denied by medical doctors in a Bavarian German prison. Sorry. And the reason for that was that the doctors would say he's not in need for an OST treatment. So they were thinking he is using some other drugs, possibly, and many other things. The Court of Human Rights found that the physical and mental strain that Mr. Wenner suffered as a result of his untreated or inadequately treated health condition could, in principle, amount to inhuman or degrading treatment. So Mr. Wenner relapsed because he was not included in an OST program in that prison. He relapsed, went to 2 court areas, but his complaint was denied and rejected. So he finally went to the European Court of Human Rights in Strasbourg, and it changed considerably because the judges found that Germany has breached and violated the European Declaration of Human Rights, because the failure to adequately assess Mr. Wenner's treatment needs involved a violation of the prohibition of inhuman or degrading treatment, and that is part of the European Declaration of Human Rights. So Mr. Wenner won in the end. That gave a considerable shift in the availability and accessibility of opiate substitution treatment in first Bavarian prisons, but then prisons in Germany at all. So this court decision was more important than lots of articles we wrote for many years complaining this situation. And so I can encourage each and everyone to finally go to the European Court, although it took 4 years to get this final decision, but it was worth doing it.